make everyone excited to receive the actual details tomorrow. Thanks. Over to you.
Okay, I hope you can all see the presentation.
Yep.
Okay, so just to clarify this, we've discussed this at the previous grouping, and what we decided to do was to actually develop a number of provisional policy briefs that deepen the aspects of the main report. So to go into specific areas and to build up a compilation of policy briefs that will go through systematically every key aspect of the health system. So there's actually solid material, at least at a certain level of strategy, a strategic take. And it becomes a point of departure for conversations on what needs to happen. The rationale is that this is in anticipation of basically a rediscussion of the reform framework for South Africa. So even though the door is kind of closed at the moment, narrowly, in essence, the country can't stay like this. The NHI can't be implemented. It's well understood it can't be implemented. And at some point the opening will come, and then the question is, what is the coherent strategy going forward? I think that a lot of the negative things happening in the health system at the moment, Tembisa, etc., and the corruption, the deep corruption, and the structures that cause it are also part of opening that conversation, because this is an indication of systematic non-performance that basically has to be addressed. And the NHI framework addresses that in no way. So the policy briefs I've got, so at the moment I've got 3 policy briefs sort of developed. They just still need some refinement to go for distribution and comment, but they've been developed in a sort of a fairly substantial way. And I'm kind of going to go through the key policy briefs that would be developed first and how they kind of fit together. So I'll go through that in the presentation. So the idea of the policy briefs is really to be able to proactively deliberate on key strategic issues. So none of this conversation is a response to government asking for anything. It's actually a response to the opposite, the fact that government is basically AWOL, and there needs to be something that fills this vacuum. And the policy briefs actually provide content that can actually provide a scope for a lot of conversations that then start to happen. And the main idea around these briefs is that they are logical, they're rational, they're common sense, they make sense in terms of what needs to happen in the health system. So just a note on that earlier discussion around how we should be communicating these issues. My view would be that initially, that in some cases, certain types of communication can lower trust in the overall process. So the communications need to have a degree of authenticity to them, which suggests that a lot of the earlier conversations are with really strong bodies. It could be trade unions, it can be early adopters in the system that would be prepared to look at this and prepared to listen for a length of time. And if enough people have gone through this, the communication itself will sort of take care of itself, and then wider communication can spread from there. But I think in attempting to actually communicate with everybody is actually problematic, because most people are only partially interested, and so they're not. The message is going to flounder. But if you're speaking to the people who are in particular interested, it's going to develop a degree of stability, and that becomes the platform from which to proceed. So the policy briefs kind of build that platform. It gives something concrete against which to have a conversation, and the conversation is not just NHI is rubbish and government isn't doing anything. This is the conversation about what we should be doing, what we can do, what our potential is, what our vision would be for the health system. So the overall goal is to focus on the strategic issues of the health system architecture, so the current architecture. And just note, I've shared the link to the SAMJ article that I drafted, which does the comparison between 3 universal health coverage models. And the term universal health coverage is being used. We've got a universal health coverage, a 0 1, and 2. And the default is the universal health coverage 0. It's what we have. It's universal health coverage, but deeply flawed, because it's just an amalgamation of partially implemented stuff, stuff that hasn't progressed, and a inertia from pre-1994 structures. So UHC 0 is actually a visionless default system. UHC 1 is a framework that has a vision that is implementable and achieves the objectives of deepening universal health coverage. And UHC 2 is the NHI proposal, which is largely unimplementable. And the argument there is that UHC 2 or NHI basically defaults back to UHC 0, the default system, because it can't be implemented. So we end up stuck where we are. So that becomes the first primary overriding message, is that unless we have a positive framework and a vision for reform, we are going to be stuck with what we've got. It's not that we will get NHI. It's not going to happen. So the health system architecture encompasses governance frameworks, accountability frameworks, and what I term here questions of subsidiarity. You'll see it in the article that I've drafted, which is a principle around decentralization, in that where you're dealing with very large systems, you don't centralize unless it can be done better by centralizing. But if it's appropriate to be done closer to the ground, you do it closer to the ground. If you saw the police discussions today with the KZN commissioner, he's talking about the real problems with an over-centralized police system, and that in fact there should be devolution. It's the same principle in healthcare, but he's not even saying it within this language. He's saying it because he actually really understands police services. Where you've got complex systems, you decentralize, you make things closer to the ground, but you make sure that you've got proper accountability mechanisms in place. Otherwise, you'll have what's happened at Tembisa Hospital. So governance and accountability means that we've got to look at those overall structures. So this is just the wider context for all the policy briefs. Accountability framework, governance framework is the architecture, the institutional framework of a health system with a public value objective to achieve universal coverage. I just wanted to clarify the principle of subsidiarity as a term, because it is a guiding principle in the design of the architecture of the health system. And it says that subsidiarity is the idea that decisions and functions should be addressed at the most local level capable of doing so, with higher level or more centrally placed authorities stepping in only when necessary. So essentially, you've got two dimensions: vertical, the allocation of public responsibilities, and that's between national, provincial, and local, and horizontal relationships to non-state actors. So the private sector, the medical scheme system, and so on. Both are encompassed in the logic of subsidiarity, because medical schemes themselves and private providers are part of a decentralized system of purchasing and provision. And provided you can properly maintain such a system, it will itself evolve in a way that protects people more effectively. So the logic of centralization is fundamentally opposed as a design principle. And now all the framework and the specific policy briefs take this into account. So you've got the overriding UHAC framework, which has been proposed. I'm not going to go through that. And I've just pointed out that these are the three universal coverage options, supposedly the options in inverted commas, that we have before us. UHC 0, which is default, UHC 1, which is recommended, and UHC 2, which is NHI, which is unimplementable. I've already described this, but in the presentation, which we'll make available, you've got the definition of what each of these are in terms of a comparative system. But I'd prefer to go into the briefs. So there's UHC 1, a broader definition, UHC 0, UHC 1, and UHC 2. So the policy briefs, 3 have been developed to date, and I'm going to talk to the main ones that would be created. So policy brief 1 is actually the corporate, what is termed the corporate governance framework for the health system. So you might not see this as an immediate impact on any person or any grouping within this grouping. But the corporate governance framework really talks to how the multiple entities in the public system are held to account for what they do in a decentralized manner. So the current framework that we have for provincial hospitals and for the districts is that they form part of a quite centralized hierarchy. So you can't really, Baragwanath isn't Baragwanath Hospital being run in a decentralized way. It forms part of a provincial hierarchy, which means that the MEC is appointing the CEO of the hospital or trying to remove them, and they report in to the system. It is a wider system of procurement and management and oversight and supervision. And the problem with that structure is that nobody is accountable for anything in the system because it's so poorly structured in terms of its allocation of decision making. So the corporate governance framework is the first brief, and it talks to how every part of the system, the principles of how the supervisor of regulators, of hospitals, of the district authority system should be organized. And it goes to those principles. If those are implemented, it takes it eliminates the corruption and the poor performance and the poor leadership that we have within the system. It is structured to eliminate that and to promote a merit-based leadership system operating throughout, from the regulators all the way through to the service delivery elements. Policy Brief 2 is a district health authority framework, which is a decentralized district authority system at the level of as a substructure within the provinces. So the fundamental idea is that the district or the primary care system must fall at a provincial level. You don't centralize this. So the NHI framework has the district health management units and CUPs and things like that, all at the first tier of government, which is, to be perfectly straight, completely insane. And this structure says, despite the fact that we've got massive corruption and problems that are occurring at the provincial level, if you structure the corporate governance framework correctly, you eliminate a large part of that. It's largely a consequence of how we've organized the accountability systems that has made them subject to capture. And note that not only provincial structures, but national structures are subject to exactly the same capture for exactly the same reasons. Members of the executive who are able to influence the appointments into structures and cadre deployment and all of those things is the method by which capture occurs, because you essentially establish networks of extraction, which you put in place at the top of the system, and the leadership you have is appalling. They have no interest in running anything in the health system properly. So the district health authority system gives a framework of decentralized authorities that are established with strong accountability frameworks in place. And I'll go into that in more depth. Policy Brief 3 is the version for hospitals, public hospitals, which is the autonomous public hospital framework, which again is a decentralized system for public hospitals. So instead of having provincial hospitals as forming part of the hierarchy of the relevant department, they become separately established public entities under supervisory boards that are not appointed by the MEC and therefore are screened off from political influence. And now you're creating very capable organizations. They might not be capable on day one, but they have through the corporate governance design will build up capability over time, but they will run their own show. They will be autonomous. You can contract with them. They can retain their own revenue. They'll be completely different creatures to what they are today. And I'll go into that in more depth. The ones that haven't been developed yet, that are going to be Policy Brief 4, is basically the medical scheme private system framework. To a large extent, it has been discussed. People are aware of that aspect, but how it articulates with the autonomous public hospital system and the district authority system would be framed in Policy Brief 4. So it's not only how the medical scheme system should be regulated, so in terms, for instance, of the framework proposed in the health market inquiry, but it also specifically talks to the articulation with these reforms that are the reformed structures of the public system. So the system actually, the systems grow together. And so that would talk about that articulation, but there's some discussion on that articulation in the briefs as they stand, but this would be a report that makes that component explicit. Policy brief 5 would be a workforce strategy framework, and deal with basically what's missing at the moment, which is the whole system of how the health professional workforce is developed, and from clinical to sort of ancillary and support staff, all of those health professionals, how that forms part of a strategic decision-making strategy and a subsidy framework, a framework that has been developed in the past. So this will be an articulation of it and showing exactly what needs to be in place for us to have this, so that we don't end up with unemployed doctors, that we don't end up with unemployed nurses, that we grow the workforce in relation to the capacity to absorb them. But we also deal with the fact that we appropriately ring fence the allocations for registrars, for anybody that's going through further training within the system, that there's a subsidy framework to support that so that it underpins a strategy. That has been developed before. This policy brief will articulate that, and it's a cross-cutting support for the full system. Policy brief 6 is the overriding financing framework of the system. So when people talk about equity objectives and cross subsidies and things like that, that will talk to that. Although they're covered to some degree in the other briefs, this specifically kind of shows the strategic picture. So the blocks with policy briefs with dots around them, that's ones that still have to be developed. The ones that are the first 3 are the ones that have been prioritized to create first. So just to talk about the different briefs. So policy brief 1, the corporate governance system for corporate governance for health systems integrity, it's called. Now note that when one uses the term governance in the sort of terminology of certainly how our school speaks of it, governance is actually the institutional architecture, wide institutional architecture of a system, which has a public value objective. So it doesn't just talk to corporate governance structures. Corporate governance structures talk to accountability mechanisms. So they're a subordinate component of your overall architecture. This framework is talking to the corporate governance, not the wider governance framework. This is basically how we lock down the public entities in health so that they can't become piggy banks for criminals. And this is where it is important when we communicate things to the public going forward, that basically what has to end is that the thieves must get kicked out of the healthcare system, and not only kicked out, locked out of the system. This is how you do it. The corporate governance design locks them out. And the idea of the corporate governance system is that it does 2 things. Is that on the one hand, it prevents and allows you to eliminate the crooks from the system and bad apples and people who can't work properly, but it also internalizes the dynamic that generates good leaders in key decision-making positions within the system. So the problem is that governance failure undermines service delivery and trust. There's political interference and cadre deployment, and I think we just have to be clear. I'm very happy to use the term cadre deployment. It is a corrosive, destructive influence on every part of our public system. It has destroyed the integrity of everything. Wherever you see it, it is a cancer. So this has to end, and we have to have professionalize the public service and our public bodies, and have people who actually are interested in public service careers in public organizations. So this is the part of the problem that has to be eliminated. You have to deal with the irregular expenditure and corruption that is rampant. It is Tembisa is a tip of the iceberg. It really is. And I perhaps have seen more than a lot of you on what's actually going on, because quite a lot of the leaks come via me from News 24. And other newspapers. And I know the characters, and I've got the documents. Some of them are now in jail. Some of them are under discussion in this latest commission of inquiry and the police inquiry in Parliament. They haven't stopped getting contracts from provincial health departments. It hasn't stopped. They've continued. So despite what the SIU did in Tembisa, I have the evidence on the other hospitals. They also have contracts with them, and the provincial departments have done nothing about that. So that just shows that the top-down corruption that occurs because of the failures of the poor corporate governance designs are going to continue unless we eliminate it. And then, of course, the NHI, as part of the problem, is that it centralizes power without fixing governance. It actually creates a governance risk on steroids. So the rationale for the reform of the corporate governance framework is that you want integrity and competence must precede financing reforms in every respect. This is basically what has to be in place for the system to start progressing toward capability. Corporate governance ensures clear roles, accountability, transparency, separates politics from management, and strengthens the public confidence. It should properly align with the PFMA, the Constitution, etc. And just to note that despite the fact the PFMA provides a very sound body of regulation to deal with provincial and national government structures and various public entities, the key problem is nobody enforces it. And that's because the supervisory structures involve conflicts of interest. That's the fundamental problem. The people who are overseeing the system won't put their friends in jail. So the PFMA is never activated. The blacklisting of inappropriate contractors in the public health system requires that the accounting officer must actually inform National Treasury and request that people are blacklisted. There isn't another procedure in which you just identify these people and blacklist them. So the blacklisting process of inappropriate contractors within the system is dependent on people who are potentially involved in the corruption. So they won't be blacklisted. So all of those things are just utterly stupid rules, but it's so easy to change them. So the key themes that come through in this brief and the reform framework is that there would be independent boards and councils. So why I'm saying councils, that's the regulators. So whether we're talking about the Office of Health Standards Compliance, to the Council for Medical Schemes, a key weakness is political appointments into those organizations. It's destroyed their integrity. You can't trust anything coming out of them. So and you know that this would be coming from somebody who set up the Council for Medical Schemes. It was the policy framework that I developed. It has been utterly corrupted by the ANC. You need potentially an independent appointments authority, which institutionalize merit-based recruitments. So this is one option amongst others to be discussed. But the idea is that there is an appointments authority that vets people, but is also independent of the executive of government. If it's subject to influence by the executive of government, it will contaminate it, and it won't serve its purpose. But essentially, what you want is a specialist body that is going to review people who end up being nominated or potentially appointed onto the boards of a range of different corporate governance structures that operate throughout the system, from people in the Council for Medical Schemes to other regulators, the Office of Health Standards Compliance, to the boards of public hospitals and the boards of district health authorities to be described. The criteria, which we don't have anywhere, becomes an explicit framework of fit and proper criteria that can enforce competence and integrity. But fit and proper criteria potentially can be created so that there is actually active review, so prospective review and concurrent review of people and their fit and proper status, and automatic exclusion from supervisory structures if any of the fit and proper criteria subsequent to their appointment actually occurs. So if somebody actually loses their fit and proper status, it can be because of misconduct. It can be because there are black and white criteria. If you don't have this, if you're insolvent, if you have a criminal record that you got while you're a board member, you are automatically disqualified from continuing. So all sorts of things can be put in that fit and proper criteria, and it creates a basis for automatic removal or for adjudicated removal. And it would include declaring people not fit and proper on the basis of their conduct, even if they resign. So they can't reoccur in the system. And then there's transparency and oversight. Public audits whistleblower protection, all of those things can be established. So the frame is basically that you're looking at multi-tiered governance, provincial boards, hospital boards, district health authority boards. The appointments authority vets leadership and board members. Boards hold executive accountable for financial and service outcomes. So the boards are meant to supervise and appoint and remove chief executives of organizations. So the chief executive of Tembisa Hospital would be hired and fired by Tembisa Hospital Supervisory Board. And it would align with various other recommended frameworks that are international. So this is throughout the entire system. So if we had to look at it, you have a national independent appointments authority, which would essentially vet the appointments to statutory bodies, regulators, district health authorities, autonomous public hospitals. So obviously certain of these are proposals in the briefs. So it supervises board appointments, recommends board appointments based on criteria. And if you still have a scenario in which a minister or an MSc must appoint, they must appoint unless criteria is not met. And that criteria is explicit. So they can't just say, oh, well, I didn't like this guy. Or, as we see now with the Judicial Services Commission, that some lengthy list is given to the president to choose 2 from 5. So 2 of those are guys who are politically connected and the rest aren't. So those 2 end up being appointed. So he's got the opportunity to appoint politically connected people. That's a problem. The issue is that actually you don't give a selection, you give the appointment. You give the people who should be there. There's no discretion around that appointment. So the members of the executive should have no discretion other than a normal check and balance on whether or not criteria have been met. And if there's no evidence that the criteria has not been met, they must appoint. So that's and if necessary, it can also be that the appointment is ultimately made by a legislature rather than a member of the executive. So this it can also supervise board member removals. So we've just seen a case where Patricia DeLille just removed an entire board in the sports framework, and the question is whether that was just arbitrary because they were canning some tender. The issue is that in this type of process, you vet the board members, you vet any removal, you vet the processes, you vet anything that happens, but you're also vetting the sort of explicit fit and proper requirements, prospective and concurrent, and you also have the powers to declare unfit. But you can potentially give those powers to other bodies as well, not just this body. So you have overlapping responsibilities in the system. It can also maintain databases of unfit board members and CEOs. So the recommendations would be to establish a health appointments authority. I'm just giving an example. This could quite easily be done in about 12 months. Pilot independent boards, amend the PFMA to allow for certain powers to be given, develop the code of corporate governance for health, and essentially restore integrity and accountability to enable universal health coverage. So that's the wider strategic framework, the principles behind corporate governance design. Policy brief 2 is the implementation of a district health authority system. So the problem at the moment is the system is fragmented, centralized decision-making, weak accountability, effectively no accountability, limited community voice, poor responsiveness, frequent stockouts. And the NHI proposals risk further centralization. It doesn't solve these problems. So the rationale is that you want a decentralized system and you want a district level governance framework that aligns with the subsidiarity principle, builds on the existing legal frameworks, and the UHC1 framework is it fits consistently into the overall UHC1 framework, which is the UHAC proposal. So key themes. Essentially, you would look at establishing an autonomous district health authority. So this means that a district becomes a very clear legal entity. It is not just a chief director falling within the hierarchy of the Gauteng Department of Health. It is an actual authority with somebody who heads it up. and it is and you would have a supervisory board that it would be accountable to. And there would be potentially a design of that board so that there is upward and downward accountability. So downward accountability to communities, upward accountability to the system, but not to just an MEC, but to province, national, but also to Treasury, but also to a board made up of experts and what are effectively what we would have in something like King 4 non-executive directors. So people of real competence who are on that supervisory board, who can be part of a strategy process for the relevant district. But now what a district becomes in our system is the equivalent of a regional medical scheme, so to speak, just to conceptualize it. It is a funder of healthcare, a purchaser of healthcare at that level. It's a distinct authority with which you can contract, negotiate with, and it has authority to plan and the health services for its context. So it can allow for the integration of care at level 1, and you can have very dedicated performance monitoring and focus on equity and access, because there would be a financing framework for the district health authority so that they actually have a very specific regional budget for that authority. The framework, district health authorities would be governed by independent boards. There'd be delegated authority over HR, budgets, and procurement. In other words, the decision space will be delegated down. The people in charge of this will be able to make their own plans with respect to HR, budgets, and procurement. The boards will supervise that. There would be implementation through provincial structures, and one can pilot this and grow it. There'd be a dedicated financial framework with equitable allocations regionally, which would include an adjustment mechanism for cross-boundary flows. Patients that go from one area, they live in one district but use the services in another. But the overall principle is that the system is designed for upward and downward accountability, not just upward to an MEC and a political party. So the recommendations, this is just a sort of kind of a superficial high-level view of what recommendations would be. You can legislate this across all provinces using national legislation. And then provinces can deepen that using their own legislation. You can establish community oversight, public reporting. You can pilot it and refine the model. You can strengthen local capacity and align financing flows. And the goal basically is an accountable, locally governed health delivery service for universal health coverage. The other issue with this model that becomes important is that because it is a decentralized public entity as such, it can enter into contracts on its own. The overall CEO is an accounting officer. They can sign and procure directly from that level, which means they can enter into agreements and collaborate with medical schemes and private providers. They can do any agreement that makes sense for that region. That's the logic. It doesn't defer into the province. Their objective is to achieve the goals, some of which are provincially determined goals, not operational decisions. But they are free to make all operational decisions to meet all goals, including goals that they set themselves in relation to contracts, public-private arrangements. So this it allows for a much more flexible and harmonized system overall at the level of level 1 care in South Africa. This is a source of integration in future. So the more capable you make the district authority, the more it will be able to actually harmonize with the private sector. The policy brief 3, so the last one I'll go through quickly, is autonomous public hospitals. So to clarify what that means, is that autonomous public hospitals, like the district authorities, have full discretion. There's one captain of that ship. They have the ability to run that hospital as a public entity, not as a subcomponent of a province. So the problem at the moment is that the system is centralized with bureaucratic control of hospitals. If we go, and for those of you that sort of, just one example, when the fire that occurred at Charlotte, and you go after a year to the CEO and say, why haven't you fixed the hospital? And the CEO throws up their hands and says, oh, well, I don't have budget. And the budget sits with DID. Go speak to province. You go speak to province, they say go speak to the Department of Infrastructural Development. You speak to Department of Infrastructural Development, they've got their list of projects and stuff. No, we don't have money for this. So they don't do anything. In that structure, nobody's accountable. After they were pressured to fix the hospital, then national department stepped in and then asked TBSA to do the repair of that hospital. Now you ask the CEO of Charlotte, why is stuff still not finalized? They say, speak to national. You go to national, they say, speak to DBSA. Again, nobody's accountable. That's not the right design for hospitals. When an autonomous hospital is that CEO's head is on the block, nobody else's. It's very clear where lines of accountability go. That's how you design public hospitals of the future. Around the world where the best public facilities are running, that's how you run them. So you remove the centralized bureaucratic control of hospitals when nobody's really accountable and you have really very weak people in charge. So CEOs, they lack authority, there's corruption, inefficiency. The MECs have appointed their networks of extraction. They are poorly managed, poor leaders, people who just shouldn't be there. So hospitals are unable to manage staff or procurement effectively, and NHI further removes the decision-making. There's nothing in NHI that deals with this situation. So the rationale for autonomous public hospitals is autonomy enables responsiveness. You're shifting the decision-making down. There's now a complete array of decision-making obligations and space allowed for the CEO. They have full control over maintenance, full control over HR, full control over how to deploy their budget and resources within that facility. But with it comes accountability. That means there's nowhere else to go. They can't say DID didn't do their thing and go speak to province or go and speak to the national department or DBSA. They're the ones who carry the can. When that's very clear, then it means that people actually do their job. But for that to happen, we can't have the CEOs that are currently running our hospitals. This is a very different CEO that's actually vetted and appointed by the board. The issue is the decision-making is now closer to service delivery, but more complete. It allows the hospitals to retain revenue and reinvest in patient care. It's a very important part of creating the link to medical schemes as well, is that if they contract with medical schemes, they keep the money and they can redeploy it within that facility subject to the supervision of the board. In other words, they can't put it in their pocket. It goes back into the hospital. And so this is basically consistent with the subsidiarity principle, pushing decision-making down and making it accountable. So the key themes, you have hospital supervisory boards. So these are not the advisory rubbish boards we have at the moment. These supervisory boards are boards with real powers and fiduciary responsibilities. The individuals in them are properly vetted and should be there, and they can do that job. MECs no longer appoint CEOs, they no longer fire CEOs. The board does. There's managerial autonomy. There's financial flexibility to retain and use own revenue. That means that if we were looking at the Gauteng Department of Health, they would be able to access the revenue streams of medical schemes as well as the government revenue streams. They would have that option if they choose to go in that direction. And so public-private partnerships and collaboration for efficiency and capacity would become much more possible. But if a medical scheme wants to enter into agreement today, they must go and negotiate with some province. They must go to the provincial head office, who knows nothing about what's actually going on in the health department. So contracts go nowhere. Now you contract with the hospital directly, with a team that knows what they're doing. The framework, so it's autonomous hospitals as juristic entities under provincial systems. There would be independent supervisory boards with merit-based appointments and independent of the executive. The boards would appoint the CEOs. The CEOs are accounting officers. There would be a mixed funding model potentially because they're allowed to raise revenue on contracts with the province as well as contracts with medical schemes. Potentially in terms of a provincial allocation, there would be a base allocation, a supply side allocation, plus a case mix adjustment, which could evolve. Very straightforward to do if you've got a competent hospital like this. And you'd have transparent reporting, etc. The recommendations, again, legislated hospital autonomy and boards can be done in a year. You can pilot autonomy in major hospitals to demonstrate value, noting that the central hospitals might have a different configuration in their supervisory board than a regional hospital, because an academic facility has a range of different stakeholders: national, academic, the universities, the province, as well as different levels of care, etc. So the board is more complex, but the principle becomes the same. So at the end of the day, the objective is that you have an empowered, high-performing hospital for universal access. The idea of this approach is that the public hospital system evolves as a high-quality hospital system into the future. So it means you're changing the downward trajectory we currently have, putting them on an upward trajectory in which the public hospital system becomes a strengthened basic part of our overriding health system that is harmonized with private as well. So to interact with the medical scheme system, you can have collaboration and contracting with provinces and medical schemes. I outline in the document just what a potential new kind of contract would be with a province and a contract with the medical schemes, the key components. The idea is that the province in future would actually contract with the facility. Province would actually have a 5-year agreement. You go to France, you've got 5-year agreements. You go to Australia, their public hospitals have 5-year agreements. You have a framework for contracting, which includes basically, we want you to have these services, we will give you the money for them. So you don't have the arbitrary budget allocations we have today. It is specific, and there's a 5-year agreement because it's long-term. Medical schemes, it might be 2 or 3 years. So there's enormous opportunities through this contracting framework for public-private collaboration. And this is just an indication of what it can look like. Here is your autonomous public hospital. Down the line, both your provinces and your district health authorities can actually contract or engage in a much more specific manner with the autonomous hospitals, because both will be strong entities. The district health authority can contract for certain services. There can be 2 ways. There's also referral structures. Medical schemes can contract at the provincial level. They can contract with district health authorities. They can also contract directly with autonomous public hospitals, and the provinces, the public contracts might be a 5-year agreement with the autonomous public hospital. They run as an entity off their own bank accounts, off their own finances, as a strong structure, and they can also interact with private hospitals where there is a willing buyer, willing seller arrangement that can be entered into. Plus, they can be networked between public and private in relation to medical scheme agreements. All that becomes possible. None of that is possible now. So this would be the final vision of why the system would benefit from autonomous public hospitals. Okay, so I've gone through those first 3, and the reason those first 3 are there is because they are the first building blocks that are critical to the performance of the overriding health system, the public hospital system, the